Great. Well, we won't, we only have a very short time, so we'll just thank you for including us in this webinar and get right to it. And if I could advance the screen, I would. Very quickly, this is an analysis intended to define the performance standards of a virologic monitoring program for SARS-CoV-2 that would permit the safe return of college students to campus for the fall semester. Our goal was to understand how total infections and isolation capacity needs might change when we varied assumptions about the things that university administrators have control over, as well as the severity of the epidemic and the frequency of screening, the quality of the screen being used, and to estimate how much this might cost in order to suggest for administrators what a notion of value might be. I want to be very clear from the outset that this is not an assessment of population-wide screening. One is required. I'm not saying that proudly, but this was initially a piece of work that Rochelle and I undertook on behalf of a consortium of university presidents in the Boston area, and they asked us very specifically to narrowly focus on students returning to campus. So while we have taken into account the importation and exportation of infections, we have ignored the impact of reopening on staff, faculty, and the surrounding communities. That's a weakness and a boundary, not something that I'm displaying with pride. Rochelle and I are a tag team here, and I want her to jump in.
No, everything, you're spot on, nothing to say.
I'm not even sure that I want to be leading. Just to let everybody here know, this is a published paper now, and it is publicly available. The link is there at the bottom in JAMA Network Open, and it is open source. So we are going to be presenting to you actually some results that appear not so much in the main tables, but in the appendices. We can explain to you why that is, but just in case you have to run off for any reason, let us begin with the conclusion and just let you know that we considered 3 different scenarios, a base case, a worst case, and a best case, each of them characterized by different reproductive numbers, 2.5, 3.5, and 1.5 respectively, as well as a certain number of exogenous infections or imported infections. And I'll explain to you more what those are in a moment. But we looked at anything from 25 to 5 with a base case of 10. And what we found was that the optimal policy in the base case was to screen every 3 days, assuming that we had a $25 test with 80% sensitivity. That would result in 6.4% of the students becoming infected over an 80-day fall semester, at a cost per student of the screening program of $700. In the worst case, daily screening would be required. It would nevertheless result in a higher percentage of students being infected over the 80 days to 16.3% at a cost of $1,000 per student. And if the planets aligned and the best case were to prevail, weekly screening would be sufficient, resulting in 3.4% of students being infected over 80 days at a cost of $300 per student. The model underlying this analysis is a pretty straightforward, standard EPI 101 SEIR model. And I'm going to assume that everyone here knows what that means, but please feel free to interrupt or send notes to the chat box if you'd like more. But basically, there is a susceptible population. There are a number of different there's an exposed population, sorry. There are a number of different infected individuals, some of whom are undetected and asymptomatic, some of whom are symptomatic and therefore detected via their symptoms, some of them who have been detected via testing, and there's a recovered population. So S, E, I, and R. There is a death population as well, but in the student population, that doesn't happen very often. What is notably different about this model from your standard SEIR framework is the fact that we are conducting testing. And so we are moving people from an active transmission pool, that upper yellow band, to an isolation pool, the orange band. Some students are here, your false positives. They're being tested, the susceptibles, the uninfected, are being tested at rate T, and with 1 minus the specificity, they're becoming detected as false positives, and they return to the susceptible population with some rate that suggesting the confirmatory test that finally identifies them as having been false positives. In addition, with some sensitivity measure, students are becoming detected and placed in isolation. So this is the isolation pool, and this is the active transmission pool. One other big tweak to the standard SEIR framework is this thing up here, this X. These are the imported infections. We are assuming that over and above that which would take place under the standard transmission assumptions of an SEIR model, that there's a certain amount of super spreading events, whether it's an off-campus party or a faculty or staff member who brings infection in from the outside. But one way or another, we are permitting ourselves to pluck an additional number of students each week from the susceptible pool into the exposed pool beyond that which would prevail under the standard epidemiological assumptions. Rochelle, anything else I should say?
The only thing I would just otherwise add is that these colors are really meant to reflect what's going on in the model, but also what's going on the campus. So yellow is people moving around doing, in their normal activity. Orange is you've detected them for one reason or another and you've pulled them out of the population. And then green is they're back in the normal population, but, or not if they've passed, but for the most part, they're back in the normal population and they're immune. They're not eligible for testing because we presumed that if you've had documented infection or even undocumented infection, that you won't get it again.
Thanks, right. And so the population of this isolation pool is going to prove to be an important performance measure in our model. I won't belabor the input data, not because they're not worth belaboring, but only because we're limited in time. And if you don't like our input parameters, I will give you a link in a moment where you can go in and change those input parameters and see what effect that will have on the model. Everything is up and running in a publicly available space so that you can look for yourselves. But basically, these are our assumptions. Again, 3 different scenarios characterized by different reproductive numbers, specificity of the test, and the number of exogenous or imported infections each week.
Maybe I'll just add that we spent a lot of time thinking about what the base case RT would be. And so I just want to sort of give you our justification. Nobody really knows how the kids are going to behave when they come back to school. We sort of made the assumption that if they're in class, and the R naught of this disease we believe to be around 2.5. We made the assumption that if the kids are in class in the normal daily activities, that it's probably the case they'd be pretty adherent to their mask wearing, that they'd probably be pretty adherent to the social distancing and the policies on campus. However, we also made some assumption that they may be less likely to do that when they were in their dorms, when it was a Saturday evening, when they were not necessarily being watched. And so we ended up sort of in the neutral zone of, yes, there would be some good social distancing, but no, there might be not full adherence. And we ended up back at a base case RT of 2.5. And then we recognized this is a piece of uncertainty in our model, and we explored it widely in these best and worst case scenarios.
By the way, we really do invite your questions, so please feel free either to interrupt or to send things to the chat box. Very quickly, just want to blow through this particular slide, but only to tell you that we explored a lot of scenarios and we played with this model a lot. And of all the variables at the disposal of university administrators, the single most powerful one is the frequency of testing. Over and over, we've seen this, and it's been confirmed by other modelers as well. But just to give you a sense of what's going on, let's look at the base case over here on the extreme left. Here you have the test sensitivity running from 70% to 100%. Here you have the number of infections being created. And here, let's point out, by the way, this is a logarithmic scale. So to use technical jargon, any differences that are visible to the naked eye are really big. Okay, and what you see here is that more than sensitivity, the frequency of testing has the greatest effect on the number of infections that can be averted. The more frequently you test, you get order of magnitude changes in the number of infections caused. And that was true in the base case, in the worst case, and in the best case. It's not really all that hard to understand why that would be. This is a virus that is transmitted pre-symptomatically, asymptomatically, over short periods of time. The more frequently you can test students and remove them from the active transmission population during the time that they are actually infectious, the more impact you're going to have on the outbreak. Rochelle, anything
And
else?
maybe I will just add, this, when we started embarking on this was May, and we were starting to think about this. And one of the questions was, we don't know what kind of test we might have available to us in September. Maybe there will be more. And so people started asking us, would we prefer a weekly 90% sensitive test or every other day 70% sensitive test? And the answer based on these results clearly show that you'd prefer a more frequent 70% sensitive test than a less frequent 90% sensitive test. And that was intuitive to us after looking at it, but not intuitive to everybody. So I think it was a helpful insight.
Right, it was a helpful insight, although for the statisticians and the epidemiologists on the call, just to be very clear, there is one huge assumption here, and that is the assumption of conditional independence between successive tests, which, after speaking with lots of people, seems like a not unreasonable assumption, because largely the false negatives, the false negatives are the result of poor collection of sample, which may not repeat itself over and over with successive testing. So testing frequency can make up for a world of sins with regard to imperfect sensitivity of the test. Okay, enough about that. We are going to show you a number of graphs that look just like this one. So let's take a moment just to make sure that it's clear what's going on. Here we're assuming the base case assumptions, RT 2.5, a test sensitivity of 80%, 98% specificity, 10 exogenous shocks per week. On the horizontal axis, we're looking at the number of days in an 80-day semester. And on the vertical axis, and by the way, this vertical axis is going to change from graph to graph, so keep your eye on it. It's not logarithmic here, but it is going to change in values, is the number of students in the isolation pool. So this is both your false positives, your true positives, and the students who arrived there as a result of symptoms. So what you see is that with daily testing, there's a large number of, the average presence in the isolation pool is about, I don't know, what is that, about 110, 120 over the course of the 80-day semester. Most of those are false positives. Now, these are not the same false positives over the course of the 80 days. Students are cycling in and out as they become detected, and then as the falseness of their positive result is identified, the confirmatory test, and they're sent back to the active population. So kids are cycling in and out. But this is a case where you might actually argue that there is too much screening going on. The epidemic is well controlled. There's not an outbreak of true positives in symptomatic kids. It seems to be well controlled. The scalloping, by the way, is the result of those exogenous shocks every week. But you might argue that this is too much testing and that we're filling the isolation pool up needlessly with false positives. And by the way, false positives have costs, right? It consumes scarce resources. The kids emerge from the isolation pool having freaked out about the fact that they were, thrown into isolation with a bunch of, sick kids. It undermines confidence in the testing program more generally. So it's not a good thing.
And maybe just one other insight here is, this is so you can keep things under real check. You don't get a lot of disease with daily screening, but people didn't realize that the downside of this, even with a 98% specific test, and we don't exactly know the specificity of these tests in the context of surveillance, is that you're going to actually have to have a reasonably large place to isolate people, because these things are going to happen when you do so much testing.
I'm going to skip the next slide and come back to it in a second, but here's that same graph again. I just showed you for daily screening, but now let's look at it in the event where we're screening every 3 days or once a week, or maybe we're not screening at all. Maybe we're doing what many universities around the country are doing, which is simply waiting for symptoms to emerge before ushering students into the isolation pool. Well, you can see that as moving from daily screening to screening every 3 days, remember the vertical axis is changing, the overall occupancy of the isolation pool goes down from about 110 to an average of about 70 or 60. A greater proportion of the students in isolation are now actually infected. They are either true positives or symptomatic. But you are beginning to see that the number of students is growing, the number of infected students is growing. Not dramatically, but it is growing, and you are only saved by the bell, that is to say, the end of the semester, for this thing not to have taken off even further. With weekly screening, Almost everyone in the isolation pool is infected. Notice that the axis numbers are getting much bigger. We're now looking at many more students in isolation and a much greater proportion of those students in isolation being truly infected. And of course, if you don't do anything but sit around waiting for students to arrive infected, you're not doing much of a testing program. A testing program that only tests students who are symptomatic is a fire department that only responds to calls once the house is known to have burnt to the ground. And that's what you're seeing here in panel D. Anything else, Rochelle?
Nope, I think you got it.
Okay. And
I think the shape of the curves are actually really telling. Sort of the things that are relatively flat, you're probably pretty safe. The things that start taking off, like the weekly screening, and we plotted these 4 kinds of graphs for numerous scenarios that you'll see shortly, but the shape is actually quite telling.
Yeah, thanks. Just want to point out, by the way, that you can reproduce every result that we present here today, as well as try your own assumptions out. If you don't like ours, you can fiddle with every one of the data inputs. This is a lovely dashboard that was actually created for us by some interested readers at the University of Wisconsin-Madison. So we're very grateful to them for doing that. But it's all there for you to play with if you'd like to. Here's what happens under the best case scenario. Under the most optimistic conditions, you probably would be sufficient with weekly screening. You would still have some students in the isolation pool, but as you can see, it's an order of magnitude lower number and a greater proportion of students, very few false positives with weekly screening, but manageable. However, that doesn't mean that you can get away with no screening at all. We explored thousands of scenarios and we failed to find even one plausible circumstance where symptomatic monitoring alone would be sufficient to control an outbreak.
We didn't drive our R0 down to 1 in saying that, but I would venture to guess that that would be hard to get to on a college campus.
I don't consider that a plausible scenario, but if you go back here and do it, the model will show you what happens. You can fiddle with R0 right there and see what happens.
And these little green boxes are really just the summary statistics, so you can see. And you know, the shape of the curve really does tell things the way we want them told. But you know, there's this general feeling like if the shape of the curve is starting to take off, you can start seeing in that second to last green line that your total of infections on your college campus is getting to an uncomfortable place. Even if you could tolerate 445 in the daily screening, you might really not want to tolerate 1,700 over the course of the semester, which means what, 25–30% of your population is infected.
Right. Comment in the chat box from Andy Mark saying at the medical center, Columbia isn't even doing weekly screening of students. Yeah, so again, you can go to the, I don't know what this, is there any regularity to the screening program, or is it simply symptomatic screening?
They were doing what they called a gateway test, literally one test, and then I guess if people have symptoms, they could self-report.
Right. So gateway testing isn't, you know, it's better than nothing, and there are better ways to implement it, of course. The idea of mailing a test to a kid and saying, get this done 2 weeks before you come to class, to school is as good as useless, but it's better than nothing. But yeah, we're looking at the ongoing program, and yeah, the fact that—
And it's important to note that actually that's what the CDC recommends. The CDC does not even yet recommend a gateway test. Right. So I think we've done a bit of a disservice on the CDC. I think the CDC has done us a bit of a disservice because they are allowing colleges and universities to comply with CDC guidelines without any screening.
The CDC announced yesterday that they don't support asymptomatic screening at all.
So now, you know, they have issued yet another get out of jail free card to every college in the country. No longer do they need gateway screening. No longer do they need to be doing monitoring of asymptomatic students. I just have 4 words for that. The CDC, is CDC a single word? The CDC is wrong. And they're doing something very dangerous. Here's the worst case. As you can see, daily screening would be required in the worst case in order to control an outbreak. So we wanted to give university administrators a handle on the question of value. Rochelle and I have been partners in crime for the last 20 years in conducting cost effectiveness analyses alongside of our model-based assessments. And so we thought we'd bring a cost effectiveness overlay to this. We realized that this may be new and exciting to many of you. So in one page, here's the crash version of my semester-long course in cost effectiveness analysis. Cost effectiveness analysis seeks to compare one intervention to another and to compute something called the ICER, the incremental cost effectiveness ratio. It's a very simple ratio. You take the delta cost of strategy A versus B, and you divide it by the delta infections. In other words, you're assessing the cost per infection averted. And the preferred strategy is the one that confers the greatest benefit without exceeding whatever external willingness to pay society or you, the payer, have to avert an infection. So, we applied some pretty crude benchmarks of willingness to pay. There is one floating out there, and we could have a long discussion about its pros and cons, but we just applied the $100,000 per year of life gain societal willingness to pay, and we translated that into a maximum willingness to pay per infection averted based on our modeling and based on RT, and it ranges from $5,500 in the best case to $11,600 in the worst case. That was what we believed.
I apologize for interrupting. You have 3 minutes left. I've taken up about 5 of your minutes, but what about pooling? Did you put that into any of your modeling?
We did not, because the Broad Institute, which was looking at, which was servicing many of the colleges that we were interested in, had said that logistically pooling would not be something they would be willing to do. But pooling is easily built into this model. Rochelle, if we've got 3 minutes, why don't you take over?
You head to the base case. There we go. So this would be the list of our costs by each of the different strategies: weekly, every 3 days, every 2 days, and daily. The list of the total infections. And if you calculate that cost effectiveness ratio, the incremental cost effectiveness ratio, the one that comes closest to but under then the willingness to pay threshold of $8,500 per infection averted is the every 3 day screening strategy. That's the one that's highlighted in gray. Fortunately, what came out in all of these scenarios is that the one that sort of felt right based on the graphs of the isolation dorms also sort of came out pretty close to right with regard to the cost effectiveness ratios as well, that you are preventing massive epidemic takeoff at a reasonable cost. So if you kind of go through the next two, David, slides. So if you did this for the worst case, the best case.
I'm sorry, Rochelle.
The best case scenario, weekly screening came out as the most cost-effective strategy. And if you did so for the worst case scenario, every 2 day screening came out as the most cost-effective strategy. This kind of kept things in check from an isolation dorm standpoint, from a total infection standpoint, and seemed to also be economically efficient. That doesn't always happen, that all of our stars align. We get all the outcomes we want with the best strategy, but that was the one that happened here.
Take the last 30 seconds to answer a question in the chat box about what turnaround time does to our model and what you think about it.
So we assumed an 8-hour turnaround time to start. That is what we were told at the beginning of this model was going to be possible by the Broad Institute, where these tests were going to be done. And David, I know you've done some work to try and increase that turnaround time. Turns out, essentially a 24-hour turnaround time turns your every 2 day strategy into an every 3 day screening strategy. So you can kind of fudge that a little bit. But really the frequency of the screening is what's important here.
Yeah. Stephen Sterling asked, are university administrators listening to us? We've had the great pleasure of working with about 25 different university reopening committees. Unfortunately, I think there's selection bias in terms of the ones that are actually reaching out to us are the ones that really care and that aren't under political pressure from governors and state boards to reopen at all costs. Yeah, it's been very gratifying.
So, David or Rochelle, are there examples of universities that are doing daily testing that you know of?
I don't know of daily testing, but I know of numerous universities here. I think there are at least 40 universities that have now contracted with the Broad Institute in Boston. I think they intend to do over 100,000 tests a day to try and get universities to be able to open at either every 2 or 3 day cadence. sites.
Right.
And we would actually urge to say that, importantly, we've gotten a lot of questions about, well, can't I start it every 7 day, and if I run into a problem, go into every 2? And the answer is no, you should start it every 2 or 3. And if things seem to be going really well, then you're going to go to every 7. But if you start it every 7, your cat's out of the bag and you have problems before you start.
But Andy, if your question is, can they do it? We recognize that we have set an enormously difficult and high bar logistically, financially, and that many universities, it will simply be too high a reach. But those universities, we think, need to ask themselves whether they have any business reopening. Simply to say it isn't feasible or it isn't practical is not the same thing as saying it isn't important.
Okay, I'm going to open this up to other people to ask questions since I've been monopolizing.
Is it possible to repost the site? Yeah, why don't I just move to that so that you can...
Or can we put it in the chat?
Oh, I can put it in the chat. Yep.
You can do both. That would be great.
Yep.
So there's a comment from James Lappin that Columbia Medical will be testing random sample of students weekly.
You know, that's an important point, because there were a lot of fun things that sort of we learned as we did this. And that is, there's actually strategy to time thinking about how you would test as well, right? In terms of outbreak prevention. So if you were going to say you had 500 tests and today you're going to test dorm A and tomorrow you're going to test dorm B, that's actually the wrong way to do it, because what you want to do is look for outbreaks on a given day and in a given dorm. So what you'd rather do is test 5 students in dorm A, 5 in dorm B, 5 in dorm C, all the way across the board. So there's actually some epi strategy into how you would do those tests.
Other questions? Do you know why the Broad is not doing pooled sampling, since it's been shown to be quite effective?
I think the logistics of it were really hard. The data, the specimen collection, you know, it could be cheaper for sure. You may actually need twice the number of swabs depending on how you pool and who is resolving the pool, where that pool gets resolved. So I think, you know, the question became, if we have a pool of 10 and you have a positive pool, do all 10 of those kids get isolated and then you resolve the pool? So it became an even larger logistical challenge that I think that they weren't prepared to try and tackle.
Marina Bonanno asks about boarding schools. I haven't been asked by New England boarding schools, but a couple of other boarding schools have reached out and contacted us. And it's a similar, not entirely one-to-one correspondence, but yes, we have done some.
There's another question from Larry Chasen. Have you ever looked at possible effects of synonymous mutations that would be present if you used error-prone PCR?
We haven't looked at that. We haven't looked at that specifically.
I'm a mathematician. I don't even know what that means.
That might have been an earlier question, sorry. And then Marina Bonanno asks, have you been asked to do such analysis by New England? Oh yeah, that's right. The question, sorry. Okay. Trying to do the question thing. I'm not succeeding very well.
The cost per test, again, James Lappin asked. So we looked at costs ranging from $10 to $100. I believe the baseline results we showed you were for a 80% specific sensitive test that cost $25. That cost, of course, has gone way down, right? With the new saliva-based protocols, they're able to wipe out a lot of the more equipment and resource intensive parts of the PCR processing. And, you know, that cost, according to the people at the University of Illinois, Urbana-Champaign, where they're now conducting 20,000 tests a day, they're getting the cost down to $3 to $5 per test. And cheaper ones are on the way.
And you could plug that right into the tool that's in